Hello friends. Welcome back to this series of lectures on cardiology for MBBS students. If you have still not subscribed to this channel, this is the time that you hit the subscribe button. In my last video we covered acute coronary syndrome, and today we will cover acute coronary syndrome. Complications are seen in all forms of acute coronary syndrome, although the frequency and extent vary with the severity of ischemia and infarction. Major mechanical and structural complications are only seen with significant, often transmural, MI. Arrhythmias. Many patients with acute coronary syndrome have some form of arrhythmia. In the majority of cases this is transient and of no hemodynamic or prognostic importance. Pain relief, rest and the correction of hypokalemia may help prevent them. Ventricular fibrillation. This occurs in about 5 to 10% of patients who reach hospital and is thought to be the major cause of death in those who die before receiving medical attention. Prompt defibrillation will usually restore sinus rhythm and is life-saving. The prognosis of patients with early ventricular fibrillation, within the first 48 hours, who are successfully and promptly resuscitated is identical to that of patients who do not suffer ventricular fibrillation. Atrial fibrillation. This is common but frequently transient, and usually does not require emergency treatment. However, if the arrhythmia causes a rapid ventricular rate with hypotension or circulatory collapse, prompt cardioversion by immediate synchronized DC shock is essential. In other situations, digoxin or a beta blocker is usually the treatment of choice. Atrial fibrillation, due to acute atrial stretch, is often a feature of impending or overt left ventricular failure, and therapy may be ineffective if heart failure is not recognized and treated appropriately. Anticoagulation is required if atrial fibrillation persists. Bradycardia. This does not usually require treatment, but if there is hypotension or hemodynamic deterioration, atropine, 0.6 to 1.2 mg/V may be given. AV block complicating inferior infarction is usually temporary and often resolves following reperfusion therapy. If there is clinical deterioration due to second-degree or complete AV block, a temporary pacemaker should be considered. AV block complicating anterior infarction is more serious because a systole may suddenly supervene. A prophylactic temporary pacemaker should be inserted. Ischemia. Patients who develop recurrent angina at rest or on minimal exertion following an acute coronary syndrome are at high risk and should be considered for prompt coronary angiography with a view to revascularization. Patients with dynamic ECG changes and ongoing pain should be treated with intravenous glycoprotein 2b3A receptor antagonists. Patients with resistant pain or marked hemodynamic changes should be considered for intra-aortic balloon counterpulsation and emergency coronary revascularization. Post-infarct angina occurs in up to 50% of patients treated with thrombolysis. Most patients have a residual stenosis in the infarct-related vessel despite successful thrombolysis, and this may cause angina if there is still viable myocardium downstream. For this reason, all patients who have received successful thrombolysis should be considered for early, within the first 6 to 24 hours, coronary angiography with a view to coronary revascularization. Acute circulatory failure. Acute circulatory failure usually reflects extensive myocardial damage and indicates a bad prognosis. All the other complications of MI are more likely to occur when acute heart failure is present. Pericarditis. This only occurs following infarction and is particularly common on the second and third days. The patient may recognize that a different pain has developed, even though it is at the same site, and that it is positional and tends to be worse or sometimes only present on inspiration. A pericardial rub may be audible. Opiate-based analgesia should be used. Non-steroidal and steroidal anti-inflammatory drugs may increase the risk of aneurysm formation and myocardial rupture in the early recovery period, and so should be avoided. The post-MI syndrome, Dressler's syndrome, is characterized by persistent fever, pericarditis and pleurisy, and is probably due to autoimmunity. The symptoms tend to occur a few weeks or even months after the infarct and often subside after a few days. Prolonged or severe symptoms may require treatment with high-dose aspirin, NSAIDs, or even corticosteroids. Mechanical complications. Part of the necrotic muscle in a fresh infarct may tear or rupture, with devastating consequences. Rupture of the papillary muscle can cause acute pulmonary edema and shock due to the sudden onset of severe mitral regurgitation, which presents with a pansystolic murmur and third heart sound. In the presence of severe valvular regurgitation, the murmur may be quiet or absent. The diagnosis is confirmed by echocardiography, and emergency mitral valve replacement may be necessary. Lesser degrees of mitral regurgitation due to papillary muscle dysfunction are common and may be transient. Rupture of the interventricular septum causes left-to-right shunting through a ventricular septal defect. This usually presents with sudden hemodynamic deterioration accompanied by a new loud pansystolic murmur radiating to the right sternal border, but may be difficult to distinguish from acute mitral regurgitation. However, patients with an acquired ventricular septal defect tend to develop right heart failure rather than pulmonary edema. Doppler echocardiography and right heart catheterization will confirm the diagnosis. Without prompt surgery, the condition is usually fatal. Rupture of the ventricle may lead to cardiac tamponade and is usually fatal, although it may rarely be possible to support a patient with an incomplete rupture until emergency surgery is performed. Embolism. Thrombus often forms on the endocardial surface of freshly infarcted myocardium. This can lead to systemic embolism and occasionally causes a stroke or ischemic limb. Venous thrombosis and pulmonary embolism may occur but have become less common with the use of prophylactic anticoagulants and early mobilization. Impaired ventricular function, remodeling and ventricular aneurysm. Acute transmural MI is often followed by thinning and stretching of the infarcted segment, infarct expansion. This leads to an increase in wall stress with progressive dilatation and hypertrophy of the remaining ventricle, ventricular remodeling. As the ventricle dilates, it becomes less efficient and heart failure may supervene. Infarct expansion occurs over a few days and weeks, but ventricular remodeling can take years. ACE inhibitor therapy reduces late ventricular remodeling and can prevent the onset of heart failure. A left ventricular aneurysm develops in approximately 10% of patients with MI and is particularly common when there is persistent occlusion of the infarct-related vessel. Heart failure, ventricular arrhythmias, mural thrombus and systemic embolism are all recognized complications of aneurysm formation. Other clinical features include a paradoxical impulse on the chest wall, persistent ST elevation on the ECG, and sometimes an unusual bulge from the cardiac silhouette on the chest X-ray. Echocardiography is usually diagnostic. Surgical removal of a left ventricular aneurysm carries a high morbidity and mortality but is sometimes necessary. Later in hospital management. Risk stratification and further investigation. Simple clinical tools can be used to identify medium to high-risk patients. The GRACE score is a simple method of calculating early mortality that can help guide which patients should be selected for intensive therapy, and specifically early inpatient coronary angiography. The prognosis of patients who have survived an acute coronary syndrome is related to the extent of residual myocardial ischemia, the degree of myocardial damage, and the presence of ventricular arrhythmias. Left ventricular function. The degree of left ventricular dysfunction can be crudely assessed from physical findings: tachycardia, third heart sound, crackles at the lung bases, elevated venous pressure and so on, ECG changes and chest X-ray, size of the heart and presence of pulmonary edema. However, formal assessment with echocardiography should be undertaken in the early recovery phase. Ischemia. Patients with early ischemia following an acute coronary syndrome should undergo coronary angiography with a view to revascularization. Low-risk patients without spontaneous ischemia should undergo an exercise tolerance test approximately 4 weeks after the acute coronary syndrome. This will help to identify those individuals with residual myocardial ischemia who require further investigation and may help to boost the confidence of the remainder. If the exercise test is negative and the patient has a good effort tolerance, the outlook is good, with a 1 to 4% chance of an adverse event in the next 12 months. In contrast, patients with residual ischemia in the form of chest pain or ECG changes at low exercise levels are at high risk, with a 15 to 25% chance of suffering a further ischemic event in the next 12 months. Arrhythmias. The presence of ventricular arrhythmias during the convalescent phase of acute coronary syndrome may be a marker of poor ventricular function and may herald sudden death. Although empirical antiarrhythmic treatment is of no value and even hazardous, selected patients may benefit from electrophysiological testing and specific antiarrhythmic therapy, including implantable cardiac defibrillators. Recurrent ventricular arrhythmias are sometimes manifestations of myocardial ischemia or impaired left ventricular function and may respond to appropriate treatment directed at the underlying problem. Lifestyle and risk factor modification. Smoking. The 5-year mortality of patients who continue to smoke cigarettes is double that of those who quit smoking at the time of their acute coronary syndrome. Giving up smoking is the single most effective contribution a patient can make to his or her future. The success of smoking cessation can be increased by supportive advice and pharmacological therapy. Hyperlipidemia. The importance of lowering serum cholesterol following acute coronary syndrome has been demonstrated in large-scale randomized clinical trials. Lipids should be measured within 24 hours of presentation because there is often a transient fall in blood cholesterol in the 3 months following infarction. HMG-CoA reductase enzyme inhibitors, statins, can produce marked reductions in total and LDL cholesterol and reduce the subsequent risk of death, reinfarction, stroke and the need for revascularization. Irrespective of serum cholesterol concentrations, all patients should receive statin therapy after acute coronary syndrome, but those with serum LDL cholesterol concentrations greater than 3.2 ml per liter, 120 mg per deciliter, benefit from more intensive lipid lowering, such as atorvastatin 80 mg daily. Other risk factors. Maintaining an ideal body weight, eating a Mediterranean-style diet, taking regular exercise, and achieving good control of hypertension and diabetes mellitus may all improve the long-term outlook. Mobilization and rehabilitation. The necrotic muscle of an acute myocardial infarct takes 4 to 6 weeks to be replaced with fibrous tissue, and it is conventional to restrict physical activities during this period. When there are no complications, the patient can mobilize on the second day, return home in 3 to 5 days and gradually increase activity with the aim of returning to work in 4 to 6 weeks. The majority of patients may resume driving after 4 to 6 weeks, although in most countries vocational driving license holders, e.g. heavy goods and public service vehicles, require special assessment. Emotional problems, such as denial, anxiety and depression, are common and must be addressed. Many patients are severely and even permanently incapacitated as a result of the psychological rather than the physical effects of acute coronary syndrome, and all benefit from thoughtful explanation, counseling and reassurance at every stage of the illness. Many patients mistakenly believe that stress was the cause of their heart attack and may restrict their activity inappropriately. The patient's spouse or partner will also require emotional support, information and counseling. Formal rehabilitation programs based on graded exercise protocols with individual and group counseling are often very successful, and in some cases have been shown to improve the long-term outcome. Secondary prevention drug therapy. Aspirin and clopidogrel. Low-dose aspirin therapy reduces the risk of further infarction and other vascular events by approximately 25% and should be continued indefinitely if there are no unwanted effects. Clopidogrel should be given in combination with aspirin for at least 3 months. If patients are intolerant of long-term aspirin, clopidogrel is a suitable alternative. Beta blockers. Continuous treatment with an oral beta blocker reduces long-term mortality by approximately 25% among the survivors of acute MI. Unfortunately, a minority of patients do not tolerate beta blockers because of bradycardia, AV block, hypotension or asthma. Patients with heart failure, irreversible chronic obstructive pulmonary disease or peripheral vascular disease derive similar, if not greater secondary preventative benefits from beta blocker therapy if they can tolerate it, so it should be tried. The secondary preventative role of beta blockers in patients with unstable angina is unknown. ACE inhibitors. Several clinical trials have shown that long-term treatment with an ACE inhibitor, e.g. enalapril 10 mg/12 hourly or ramipril 2.5 to 5 mg/12 hourly, can counteract ventricular remodeling, prevent the onset of heart failure, improve survival, reduce recurrent MI and avoid rehospitalization. The benefits are greatest in those with overt heart failure, clinical or radiological, but extend to patients with asymptomatic left ventricular dysfunction and those with preserved left ventricular function. They should therefore be considered in all patients with acute coronary syndrome. Caution must be exercised in hypovolemic or hypertensive patients because the introduction of an ACE inhibitor may exacerbate hypotension and impair coronary perfusion. In patients intolerant of ACE inhibitor therapy, angiotensin receptor blockers are suitable alternatives and are better tolerated. Patients with acute MI and left ventricular dysfunction, ejection fraction less than 35%, and either pulmonary edema or diabetes mellitus further benefit from additional aldosterone receptor antagonism, e.g. eplerenone 25 to 50 mg daily. Coronary revascularization. Most low-risk patients stabilize with aspirin, clopidogrel, anticoagulation and anti-anginal therapy, and can be rapidly mobilized. In the absence of recurrent symptoms, low-risk patients do not benefit from routine coronary angiography. Coronary angiography should be considered with a view to revascularization in all patients at moderate or high risk, including those who fail to settle on medical therapy, those with extensive ECG changes, those with an elevated plasma troponin and those with severe pre-existing stable angina. This often reveals disease that is amenable to PCI or urgent CABG. In these cases, coronary revascularization is associated with short and long-term benefits, including reductions in MI and death. Device therapy. Implantable cardiac defibrillators are of benefit in preventing sudden cardiac death in patients who have severe left ventricular impairment, ejection fraction less than 30% after MI. Prognosis. In almost 1/4 of all cases of MI, death occurs within a few minutes without medical care. Half the deaths occur within 24 hours of the onset of symptoms and about 40% of all affected patients die within the first month. The prognosis of those who survive to reach hospital is much better, with a 28-day survival of more than 85%. Patients with unstable angina have a mortality approximately half those with MI. Early death is usually due to an arrhythmia and is independent of the extent of MI. However, late outcomes are determined by the extent of myocardial damage, and unfavorable features include poor left ventricular function, AV block and persistent ventricular arrhythmias. The prognosis is worse for anterior than for inferior infarcts. Bundle branch block and high cardiac marker levels both indicate extensive myocardial damage. Old age, depression and social isolation are also associated with a higher mortality. Of those who survive an acute attack, more than 80% live for a further year, about 75% for 5 years, 50% for 10 years and 25% for 20 years. With this, we come to the end of this lecture on acute coronary syndrome. Hope you enjoyed the video. Do not forget to like, subscribe and share the channel. Do post your comments and queries related to the topic and stay safe.